Welcome, everybody. We are glad to have everybody together again at the Global Response to COVID-19 webinar session number 10. This meeting is sponsored by the Pan American Trauma Society, the American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, and supported by University of Miami and Virginia Commonwealth University, VCU. I'd like to say thank you, everybody, for connecting again. This meeting has been recorded, and staying in this meeting, you agree to have your image or this recording posted on the Pan American Trauma Society website. I'd like to ask Dr. Michael Butanos from VCU to say his first words and to introduce the panelists, please. Michael.
Okay. Thanks, Antonio. Thanks, everybody, and welcome. So again, this week for our 10th session, we have a full list of experts from around the world. So I will introduce the panelists. Then at the end, Dr. Martos will introduce our speakers for this week. So as far as the panelists, again, we have with us Dr. Thomas Scalea, Pan American Trauma Society Executive Director and Professor of Surgery at University of Maryland School of Medicine, Physician-in-Chief of the Adams County Shock Trauma Center in Maryland. Should be joining us Dr. Coimbra, he'll probably join a little later, Executive Director of the World Coalition for Trauma Care, Surgeon-in-Chief of Riverside University Health System Medical Center, and Professor of Surgery at Loma Linda University School of Medicine in California, USA. Dr. Felipe Vega should also be joining us, the President of the Pan American Trauma Society and Trauma Surgeon in the Department of Surgery at Hospital Angeles Lomas in Mexico City. Dr. Ken Beaufort, Professor Emeritus at the Department of Surgery at the University of Witwatersrand and Trauma Director and Academic Head of the Mill Park Hospital Academic Trauma Center in South Africa. Dr. Alan Schwartz, Director of the Trauma Unit Department of General Surgery at Shaare Zedek Medical Center in Jerusalem, Israel. Dr. Hayato Kurihara, Associate Professor at Humanitas Research Hospital at the University of Milan in Italy. Dr. Rafael Barrera, Director of Surgical Intensive Care Unit at Northwell Health, Long Island Jewish Medical Center in New York, in USA. And later will be joining us, hopefully if he can, Dr. Lee See, who's Trauma and Emergency Surgeon and Clinical Director in General Surgery at Auckland City Hospital in Auckland, New Zealand. So welcome our panelists, and I'll turn it back to Dr. Martos to introduce our speakers.
Thank you, Michael. This week, we're going to focus on the recovery phase, the reopening, the challenges, and the planning that multiple countries are facing. We're going to have three great presenters. We're going to have Dr. Vigneshwar Kasirajan, Stuart McQuarrie Professor and Chair of the Department of Surgery at Virginia Commonwealth University, VCU, in Virginia, USA. Dr. Tina Gardner, Professor and Director of Trauma at the Oslo University Hospital, Ullevål, Norway, and past President of the IATSIC. And Dr. Sandro Rizzoli, Medical Director at Trauma Hamad General Hospital, Editor-in-Chief of the Pan American Journal of Trauma, and co-editor at GINTEC in Qatar. It's going to be great presentations, and after presentation, we're going to have a pool of questions. Then all the panelists are going to discuss with the presenters the questions from the audience. So please, Dr. Butanos, say the welcome to all the associated societies around the globe that have joined this meeting, please.
Yeah, so this is, again, it's a pleasure to have all our associated societies. As you could tell, we have more than 48 societies from around the world joining us with their representatives, and we appreciate all their help and their support. We hope we continue to have this session and provide all the significant amount of knowledge and sharing. So thank you.
Thank you, Michael. So the Virginia Commonwealth University VCU has been supporting the Pan American Trauma Society for many years and is a great partner in the society. Michael has been very active in the society for multiple years. And it's a really pleasure to have here with us today Dr. Kasirajan, the professor and chairman of the Department of Surgery at Virginia Commonwealth University. We're going to talk about reopening phase challenges and how he's managing these challenges at times at the VCU. Dr. Kasirajan, welcome. Thank you for being here. You can start the presentation, please.
Yeah, I'm delighted. I didn't really have a formal slide presentation. I thought we should keep this more as a conversation because I don't think any of us, including myself, fully understand what the long-term consequences are, short-term or long-term consequences are of this current pandemic with the SARS-CoV-2. So what we did at the beginning of the pandemic when it hit Virginia was to very rapidly de-escalate our elective surgical services, as all of you had done all over the world, to restrict our exposure to patients who were potentially infected and to limit the spread of the disease. Now, fortunately for us in Virginia, we did not see the expected numbers of patients that may have hit us if the full pandemic had happened. The original projections for us were over 150 admissions per day, perhaps up to 1,000 patients in the hospital, and more than 10,000 hospitalizations across the state of Virginia, which fortunately did not happen. So for us, what happened is we ended up seeing about 40 to 50 patients a day in the hospital as an inpatient, and then we dropped down to around 35. Now the numbers are going up slowly again to about 45 inpatients at any particular time at VCU, telling us that there is going to be a slow, constant, almost like a plateau phase that we don't know how long it'll last, perhaps for months, maybe a year and more, depending on the development of immunity in the community, as well as the development of effective vaccines and other things. Now, clearly, we cannot pause all operations for months and years, which would be a major impact to the economy of the region. Just to give you a sense of the impact in the US alone, and I'm sure it's much more significant across the globally, the United States is facing the worst unemployment crisis since pre-World War II times. Currently the unemployment is estimated to be 25% of the population. Now the US, unlike many economies, many countries, is dependent heavily on health insurance through employment. So with loss of significant employment, I think what we're going to see is not just the impact of the virus and the illness, but also the consequences of people being unemployed and not having any health insurance. So I think that's a challenge that I think we still haven't fully understood and we will need to face. And again, institutions like ours, which are a major safety net hospital, will face a disproportionate share of the care of these patients. So that's one part of something to think about. The other is that, as we slowly ramp back up our clinical operations for day-to-day functioning, not just for surgery, but for other services such as outpatient visits, testing, radiology, laboratory visits, and other things, we're going to need to figure out how we're going to need to live in a world where the SARS-CoV-2 is now a part of our daily vocabulary. And we're always going to have a significant number of patients in the hospital, maybe 50 to 100 patients at any particular time, but at the same time be able to continue our day-to-day operations without significant interruption. So during this pandemic, when it started in April for us, and at a time when we ramped down elective operations, our trauma volumes and emergency surgery and other non-elective operations such as transplantation continued to actually increase in volume. So we did not actually ramp down any of those things. In fact, I think that Abutanos was telling me that the trauma and other surgical volumes may have gone up slightly. So that's kind of the reality of where we are. Now, the question of how we're going to handle that long term is something for us to work through over the next many weeks and months. So just as a practical situation, we can no longer bring patients into the hospital for elective operations all at one time in the morning, because you don't want to have 100 patients coming in the morning waiting for surgery along with their families. So we don't allow families to come in, which creates its own significant impact for patients coming in for major operations where families cannot be present with them. And then we don't, at this point, we're not allowing families to actually come into the hospital in the postoperative period. And then when we discharge patients home, we need to understand the impact of how do we educate patients, how do we teach family members to take care of these patients when they go home, particularly after complex operations such as like a liver transplant or other major operations. I don't think we fully understand the challenges of this and how we're going to work our way through it. Patients are fearful of coming into healthcare environments where they're afraid that they may develop, the disease associated with the virus. And we have to be reassuring of them that we're going to be able to safely protect them without us fully understanding how we're going to actually do it. Now, we are testing all patients coming into the health system for an elective operation or any admission. Now, is that enough to isolate the patients? We don't know. Now, in the last few weeks, we looked at over 500 patients that we tested preoperatively. I believe only one patient actually tested positive, which is a little bit reassuring. And we haven't had any of the patients who had surgery who then have gone home and who have come back positive. There was one patient who had cardiac surgery that 2 or 3 weeks after surgery became positive for COVID, the coronavirus, but never really manifested the disease process, which is also reassuring. I'll stop here and we can have the other presenters go forward and we can take questions. But a lot of it is very much unknown for us. And I think luckily for us, we were not hit really hard, and it is important for us to learn from other institutions who unfortunately have had to deal with a larger volume of patients and a much significant economic impact to their society as a whole. Again, I appreciate the opportunity and thank Mike for giving me the opportunity to be here.
Dr. Kasilajian, thanks for your words. You mentioned very important topics. You have very pertinent questions. And then I don't know if you all know the answer for your questions. But for sure, I personally going to have some questions for you during the discussion. I'm sure that a lot of people are going to make questions based on your comments, please. Thank you very much. We're going to go now for Dr. Tina Gardner from Oslo, Norway, for her presentation.
Okay, I will try to share my screen from here. Now, where did that go? There we are.
Just about at the middle of your screen. There you go. Great.
I'm blind. Can you see it now?
Yes, great.
Okay, thank you very much to Michelle and Antonio for inviting me to speak, and I can just support and agree with everything that was said with Dr. Kasirajan before me. I come from a country, you see it just in the middle of the slide, just over the title. It looks small, but it's big compared to the population, about 5 million people. So social distancing should not be a big problem. We also don't have the Latin sort of personalities in Scandinavia. So it also it helps us with being serious about social distancing. Looking at, so this is from my hospital is Oslo University Hospital. It's several locations. It's the only major trauma center for one of the 4 regions. It covers more than half of the Norwegian population, and it's also at the same time, so it's the largest emergency surgical, emergency medical, and the main COVID hospital. And it's not like we can just decide that take some of the functions or one of the functions and put it in another hospital. So the different functions have to co-inhabit during this period. We had, like some of you probably know, we had some experience with mass casualty incident some years ago in 2011 with testing of the disaster management plans and so on. And what we see, we've been working with our updating disaster management plans, and what we found before this came along with the pandemic, that that it's never purely a surgical or purely a medical incident, and that the experience that we had from planning or thinking through mass casualty experience and trying to take the simple messages out of that was quite helpful in the planning of this situation, although the fact that this goes on for a long time is very different. But I think that our main sort of what we learned from then was training logistics or making good plans for logistics in upcoming situations like this one is one part of it, but building your everyday system so that you only increase on that day. Yes, you have to invent and you have to improvise, but building on everyday your everyday system, and also building on your everyday competence. You don't rise to a new competence on a day with a mass casualty incident. In a situation like this that goes on for months, it's a little bit different, because then you have to build some other competence into part of your personnel. And this is a very new, I think, what is very different from a mass casualty situation. But it also says that I think surgeons and internists and anesthetists have realized that they have to work together in this, even if it's a medical disease. What we saw, if we look at the dates, the upper graph is showing the number of patients testing positive. So the increase from when we had the lockdown early to mid-March until around mid-April, we had a quick increase in hospital COVID positive patients in our hospital. What we saw, the red line is then patients in ICU, the green line is patients on ventilators, and the black line is then to increase the death rate, basically. The lower graph is showing trauma patients, the trauma patient influx during the same weeks. I was trying to put them so that they actually more or less the same. And if you see from week 10 to week 14, the green line, so the red line is 2000, well, you probably see it better than I, because it's behind the pictures, but the green line is now in 2020. So the dip in trauma, we were down to about sort of 40–50% of our normal trauma cases until for about 2 or 3 weeks, and then it has come up again to normal. It was very clear the decrease. We hope this also go through and get better routines. But now we're back to normal, and we're back to focusing on actually giving as good care as normally to those patients. Same thing with emergency surgical patients. That was also a dip down with the emergency surgical patients for a few weeks. We all know our goals normally, and actually we spend quite a lot of time in our hospital and in our systems and in our region to discuss and actually remind people to focus on maintaining quality of care in also non-COVID patients. And I think that has been quite important. I think a lot of the unnecessary morbidity, mortality is because of all the focus to the COVID patients and all the fear of this disease that we know not enough about. So maintaining quality in trauma and emergency surgery, and our normal principles, and instead of keep it simple, I renamed that keep it similar. So keep the same protocols, the same infrastructure. Try to maintain your trauma care in the same place you normally do it. Try to maintain the same quality of the protocols. Don't change protocols. Don't change indications, and so on. In spite of all the challenging logistics around COVID, unclear, non-tested, isolation, and so on and so forth. And also, competence doesn't change overnight. It doesn't make you an intensivist, even if you have a 3-hour course. So trying to sort of help out and make good plans for maintaining quality in all these patients has been challenging, and is plans we have to make that will have to last for months and months. And like the previous speaker said, we have no idea how long. Our trauma room is still the trauma room. Even if we are not able to isolate one bed from the other, we have to make plans for actually securing the patient as much as possible. We worked very closely with our microbiologists and virologists to decide what is safe, what is a safe distance, and how do we not overuse PPE, and how long do we have to shut down between patients when we're not sure until we have answers from the COVID tests and so on and so forth. Same thing with our CT scanner for trauma and the operating room for trauma. We don't change indications. We still say emergency surgery is emergency surgery. We have to just then secure it if we're not sure. And that means that how we dress and how we secure ourselves is different, but this is an anesthetist with an FFP3 mask. And this is the rest of the team, where some of them wear normal masks because they're not going to be close to aerosol generating procedures. And some are actually without any security because they're more than 2 meters away from the patient. And this is something we actually had long discussions and problems making everybody understand that it's not dangerous to be, if you stay far away, you don't have to abuse of PPE. And okay, maybe this is risky, maybe this is, and then we have to monitor the numbers as much as possible. This is our trauma system. So the trauma system, and we've been monitoring our region as well, because people started to become creative about who is going to the trauma center and not. And we said, okay, so the triage criteria have been kept exactly the same all the way. Yes, we have been monitoring it more closely than normal, but we have made sure that we are not downgrading or under triaging patients to care. For the personnel, if you see the quarantine graphs, the left graph is begin in the early March, and huge, so 2,000 patients, 2,000 of the personnel in our hospital were in quarantine at one time point, which is scary. This has gone down, as you see on the right graph. The blue line is going down to much fewer people in quarantine because the fear, and we get used to the situation. At the same time, the infected personnel has been relatively sort of acceptable, and no deaths in our personnel. We have had discussions around how to contribute, and one of the main challenges have been that trauma competency is not something that you can just drag in from the street or get someone else to cover. And it's a very small personnel group that actually covers, or from the surgical and anesthesiological side, that can cover trauma. And that means we've tried to protect that, at the same time contributing to the overall good because of lack of personnel in other parts of the hospital. Protecting the care of the trauma patients at the same time protecting safety of our personnel. What we ended up seeing is we have 19 infected COVID positive at the moment from personnel in our hospital, but so far until now, from mid-March, only 4 anesthetists have been tested positive for COVID, only 1 surgeon. And this is in spite of not being completely paranoid and not using FFP3 masks for every single surgical procedure and so on, because we can't afford it. Only 1 trauma patient has been tested positive during that whole period. That means if you look at the test, these are all the tests done in our hospital, and the red part of the graph at the bottom are the positives. That means we're now down to 0. So we have 100% over triaging for testing in our emergency department the last week. And now we're considering, the whole hospital is now deciding that we are not now going to restrict and reduce testing, but we have to monitor. If this then increases again, we will have to go back to square one and start wondering, how do we restrict, how do we become more strict again? This is our surgical activity. You see the blue columns on the upper graph is from 2019 to 2020. You see the graph from week 11 onwards. Electives have been very low, surgery has been very low, but it's coming up again since we started doing more surgery from week 16 after Easter. And if you look at elective and emergency on the lower, the emergency has been obviously been operated all the time, as they should. And then electives is now back to almost normal level. I think this is just to show you that remind that education is important, and we're all frustrated. We're not able to do any sort of ATLS or surgical skills courses or simulation training. And we do need that. We do have a lot of turnover in our personnel, and we see that in the competency and in the performance of our teams. And we are looking forward to the time when we can actually start training our teams together again in the different versions. Now, this is one of the last slides, and I told you Norway is a big country compared to the 5 million people, but on the 17th of May, this is our national day. This was 3 days ago. This is how it looks. This is our independence, our Constitution Day. This is how Norway looks on 17th of May, and everybody's out, and it's a completely holy celebration. And we were really worried, all of us, what is going to happen in this. This was from last year. This is now not from this year. And people listen to our politicians and our leaders. And this is actually more or less what was happening. People found creative ways of being in processions, celebrating, but with social distancing, keeping together with the people they could be together with. This was mentioned that the emergency, so the ECTES Congress was canceled like every other Congress, probably the whole of this year. But we got it cancelled, but postponed to next year in April, and hoping that we can be back to updating our knowledge and communicating and networking physically again, and hope that people will want to join us in Oslo in April. So I think there are many ways to the goal, many ways to start working normally again. I think keep it simple, keep things as normal as possible. I think it depends on the setting. I think it depends on clear leadership. We have the fortune of having, to the right here is one of our very active internal medicine specialists, who's also a CBRNE specialist, who has been close to the Directorate and the Prime Minister for all the decisions that were made about restricted and so on. Social distancing and quarantine will be maintained. I think we have to keep on focusing on trauma and other emergencies to keep quality, even if we will continue like the previous speaker was saying about we will continue being in a weird situation. We need to pick up speed again on the other issues. We are in a total public health care system. But we're behind on all our cues, and people are needing surgery. We need to plan for a new surge, and we need to monitor so that we can actually become more restrictive again if that happens. In the middle of all this, we are planning for new hospitals and in smaller hospitals for the future, which is a huge challenge to try to put preparedness into that, and we will use COVID for all it's worth in that planning. I think the connection, my last word is the connection between our main politicians, is our Minister of Health, and the clinical leadership is what is important, and that the politicians have the guts to actually be clear in their messages to people, because like was said already, we don't know where we're going with this. Someone has to make decisions and take the blame afterwards if it was wrong. Thank you.
Thank you, Dr. Gardner. Great presentation, important topics. I'm going to have a very interesting discussion in a few minutes. Let's go now for the presentation of Dr. Sandro Rizzoli from Qatar, Hamad General Hospital. Dr. Rizzoli, I'm looking forward to listen to you, sir.
There we go. Here, and then here. Okay. So, Dr. Martels, Dr. Aboutanos, thank you very much for the invitation. So to talk about restart after COVID, strategies, challenges, first impressions. I can already tell you that this presentation will be heavy on first impressions and very light on the strategies. I have no conflict of interest, except my loyalty to the journals. Don't trust my numbers, even though I got them this morning. They may be incorrect and outdated, And those are my views, not the views of Hamad, not the views of the government of Qatar. So Qatar is a unique country. It's very different from Canada, where I lived for 25 years, or from Brazil, where I was born. So let me tell you a little bit about this unique country. It's a very tiny country in the Middle East. We have less than 3 million people. Most are men, young, and the big event coming up is the FIFA World Cup in 2022. Actually, the year there is incorrect, and we're on schedule for it. Recently, the Minister of Health, Dr. Al-Kwari, went to Al Jazeera News, and she was explaining what was going on with the COVID. And she said that the restrictions were put in place based on science. So lifting these measures will also be measured on science. I applauded her. So she also warned that the opening of the country is going to be gradual. And this is going to be a different world. So even if our airport opens, doesn't mean you can fly to Oslo the next day, because maybe Oslo is not going to let us come in when we land at the airport. So Qatar had the first case in the end of February. A few days after, we had already lots of restrictions put in place. Stay at home, and then gradually schools closed, and gradually airports closed. Certain areas of the country were clustered, and they started a massive testing campaign. And it changed the curve. It flattened the curve, it delayed the peak, and actually we are going through the peak today. Actually, this week is the peak of the infection in Qatar. So there's lots of contact tracing. There's an app called Etheras that you can see on the right-hand side that's mandatory now to all citizens of Qatar. Basically trace whoever you get in contact with. And if you're getting in contact with an infected person, you're quickly put on a list and you're informed of that. The government also designed some hospitals as COVID hospital, created some new lodgings, some temporary hospitals. Today, we have a very high number of infected people, and probably the reason is because there's a lot of testing being done. So we estimate that probably Qatar is one of the closest countries to the real number of infected people because of the number of tests that haven't been done. Today, at the peak, we're seeing more than 1,400 new cases a day. We're seeing about, 80 people endotracheal intubation, and we have about 13, 14 people on ECMO. And so far, despite all these large numbers, we had only 16 deaths. It's the lowest fatality rate in the world. And here's some graphs that show you that the number of tests. So Qatar is the country in the world that has the most tests per population. We are above Belgium, New Zealand, Australia, and so on. These are the numbers who are published every day, and I told you don't believe them, but they are close to. So we have about 1,400 new cases in the last 24 hours, and we have not 15, but 16 deaths. Those are the total number of infected, number of new cases, number of deaths, and as I told you, we have one more, and we have the lowest fatality rate. So something happened different here in Qatar. Something changed. Something was, in my opinion, done correctly. So what was done here? What was the strategy in Qatar? So Qatar, very early on, set up a command center. It's called here SWIC, System-Wide Incident Command Center. It's a medical operations center. Very quickly, they got Weill Cornell University to come up with numbers. What's going to happen? And Weill Cornell said, the worst day in Qatar history, we will have 300 people in a critical care and 207,000 people in an acute hospital. So we need 3,000 beds. So then this command center quickly started designating some hospitals as COVID, some other hospitals as non-COVID. As you can see on the left-hand side, Cuban, CDC, Hassan Mubarak, they're all designed as COVID hospitals and quickly getting all the resources to treat patients. At the same time, some other lodgings were being opening. So in Qatar today, if you test positive, you go to a government lodging. You don't stay at home. Even if you have no symptoms, you're isolated, you're put in an institution, and you're fed, and you're cared for, and you're monitored, and you're tested again and again. At the lower of this slide, you can see the activation plan for COVID. There was a first line who actually created 2,100 beds for COVID. There's a second line who actually created an additional 1,500. So we had all the beds we needed, according to Weill Cornell, for the worst day. The fact is, all these measures did something. They changed the curve, and we never got even to half of those numbers. So our worst day has been 170 people in the ICU and about 1,500 people in the hospital. So this is our trauma center here in Qatar. It's the only trauma center in the country. And that picture on the top there is from the old good days when we could just get on a plane and visit each other. So that's Dr. Coimbra and Dr. Martos when they came here a long time ago, 5 months ago. And they visited our modern new trauma tower. On the right-hand side, you can see my colleagues here from Qatar, Dr. Altani, Dr. Peralta, whom I thank very much, and it has been a privilege to work with them. And this is the picture of our trauma center. If you look on the right-hand side, you're gonna see our trauma base. They are wide, they are single units, and they are separated one from the other with walls and glass. So fortunately for us, we didn't have to make any change to accommodate for patients coming in with a COVID. Also, fortunately for us, our hospital has, our trauma ICU has beds, has rooms with negative pressure, the same for the operating room. For the trauma resuscitation unit, we have portable PAPRs, we call here HEPA filters, and we're able to designate some rooms, particularly for COVID trauma patients, if we know they are COVID. The fact is, we don't know. Most of them come off the street and there's no time to test, but every patient is being tested here in Qatar. So the patients arrive in the trauma unit, they are immediately resuscitated, and they are placed in a step down or in the trauma unit until they get their COVID test, and then they are moved to other place of the hospital. Or if, let's say, they have an isolated extremity fracture, no other injury, they may be actually transferred directly to a COVID hospital like the Hassan Mubarak. That's one of them. What we saw here in Qatar, we saw an enormous change in the population that we serve. We used to see almost exclusively road traffic and construction patients. Now that has decreased significantly, and we have seen an increase in interpersonal violence and suicide. I remember last week, Dr. Scalia said that in Baltimore, they are seeing the real suicides. And that's the feeling here too. We're seeing, I don't know, worse attempts. The patients, they are more, I don't know, aggressive in their suicide. I don't know how to describe that. And we faced, as a trauma center, as a hospital, as a country, the same changes as the rest of the world, and I'm not gonna go through them. I want to give you an idea of how I think it's gonna be the world post-COVID, and what are the strategies to restart the country, the trauma center, the hospital. So as I said, I'm very optimistic about the future. I think that's going to be like Mad Max movie. You know, that's how I see it. And if you notice, the gentleman on the right-hand side is using an N95. So I applaud him because he's wearing the right, you know, protective equipment devices. Very good. So I think that they're very optimistic about the world. What I think is going to happen to the world? I think I'll say the obvious, as Dr. Kasirajan mentioned. There's a looming financial crisis. There's a huge crisis. Someone will have to pay the bill. someone who will pay for all the lost jobs. Unfortunately, I think the world's going to be more polarized. It's going to be more us versus them. And I think too, there'll be more surveillance. I think that privacy is going to shrink. I think electronic is going to reach even unthinkable points. So if you think that your smartphone measure your oxygen saturation is fantastic, if you think that your smartphone doing continuous ECG, EEG, and able to diagnose you're having a heart attack is fantastic, just wait to see what's coming. So Dr. Martos, no, you're right? So everything's going to change. It's going to be point of care testing at home. You're going to have access from your computer. So today my GP called me. That's my office visit. He called me. He ordered my lab online. He referred me to another colleague online, and we talked online. So the world's going to be different. So a few things, my point of views. Education. Medical school will have to change. Education will have to change. Do we need in-person classes? Can't we have anatomy classes? Maybe we should do Virginia Medical School with Qatar University. We should share. We should hire only one person to teach anatomy. And then we're going to need virtual reality. Again, Dr. Martos, Dr. Fraga, simulation is going to reach points that we can even imagine. So now let's talk about what most of us do, surgery. So the question that I have today is that, are we that wrong? Do we really do too many tracheostomies? Do we really do too many appendectomies? We're seeing now patients not being operated on appendix and not dying. We're seeing patients now not having their bones fixed, and they're doing okay, right? And we insisted so much on early bone fixation. Or all these are going to come back and bite us in a few weeks. Are we going to see tracheostenosis that we've never seen before? We're going to see gallbladders that we've never seen before. We're going to see patients dying unnecessarily or suffering because we have to postpone life during this COVID era. So here's what's going to happen in Qatar. Preparations for the World Cup are going to keep going ahead. We're on schedule. It's not going to be stopped. That's the big event. We have a few years. I hope most of you are going to come to Qatar. I'm looking forward to it. There will be a gradual resumption in health. I think there will still be coordinating centers. There will be command centers. Actually, we'll work here in Qatar at a national level. We'll set up the principles and a nationwide approach to health. I believe testing is going to go even higher. Massive, massive testing. We need to know what's going on in my city, in my area. We need to know when people can go back to work, when the nurses can go back to the trauma unit, when can the corner store employee go back to work, and when's the right time, what can be open. And it's going to be a phased opening. Of course, the priority is going to be for canceled operations and for cancer. For trauma, we actually never change much. We change what we do, but we don't change their care. We're completely going on. And I completely agree with Dr. Namaya's statement last week. We learn how to live with HIV. We'll learn how to live with COVID, but it will be a different world. And I will end here with research, of course. I recommend this paper from the New England Journal published a few days ago. It says that the world is going through a biopsychosocial crisis that is unprecedented. And we as physicians should be the voice of reason and lead by example. We should be very careful in proposing untested remedies. On the contrary, we should push our patients to go into trials. So if I anticoagulate all my patients and there's no evidence it works, if I have one patient who has a hemorrhagic stroke, is that just just happen, or am I harming my patients? I need 2,000 patients to know that. I'll never know that in Qatar alone. So we should be putting our patients into trial. And if you do participate in a trial, consider submitting to the Pan American Journal or to GEMTEC. So the Pan Am Journal just came up with the latest issue. I invite you to go online. It's free, it's open access, and I look forward to get your work. So once again, thank you very much. Shukran to everybody for this opportunity.
Thank you very much, Dr. Rizzoli. A great talk, great points for discussion in a few minutes. Let's go now to a quick pool questions. Valeria, please launch that. I'd like to invite everybody to answer these questions. They're going to realize they are similar to the ones I had the previous week, but they want to compare what happened in 1 week. So first question, does your country area have social distance practice in place? Okay, you have just answered that. Okay. Second one, does your country has currently a lockdown in place? It's number 2. Number 3, where does your area of vision practice or practice fall in the curve of daily COVID-19 positive tests? Are still increasing a lot, a little bit increasing, not increasing plateau, slightly decreasing, very decreasing, unable to determine? So what's happened to your region, to your country right now, in case on new cases? Number 4, you have protocols to treat the COVID-19. You follow protocols and guidelines in your institution. Or a physician can do whatever he wants. Okay? Yes, no, or unknown. Question number 5. Are ER or trauma providers in your facility wearing N95 masks in all times during trauma or ER care? Okay? All of them are using, most of them are using, half of them, less than 50%, no or unknown. Question number 5. Number 6. I'm going to do this again. Are you performing percutaneous tracheostomy on positive COVID-19 patients? Yes, I'm doing open tracheostomies for positive patients. Yes, but doing percutaneous tracheostomies. Yes, but I'm only doing open tracheostomy after the patient has 2 negative tests. Yes, but I'm doing percutaneous tracheostomy after 2 negative tests. No, I'm not doing at all tracheostomies on patients that had positive COVID-19, or I don't know. Okay. Question number, next one, number 7. Is your facility performing laparoscopic or thoracoscopic procedures on trauma and ACR patients, both positive or negative? Yes, I'm doing for both positive and negatives. Yes, but only I have a negative COVID test. Yes, but only after a negative CT scan. Yes, I'm doing on both positive and negative patients. No, I'm not doing any laparoscopic procedures on these patients. Okay. Next question, number 8. Did your hospital change trauma protocols or guidelines at the trauma bay or operating room due to COVID-19? Yes, I changed for all patients until you have a negative test. Yes, but only change once I know the patient is positive for sure. Yes, but only until I have a negative CAT scan. Yes, for both patients, positive and negative, I change the protocols, no or a no. And question number 9. All the panelists mentioned that, is trauma training to residents and fellows at trauma bay and operating room affected to COVID-19? Yes, since the resident fellows has less exposure until the patient negative tests, so the positive tests, decreasing exposure for residents and fellows. Yes, but only for the patients that are positive. Yes, since you had less time to teach until the risk of exposure is negative. Yes, on both positive and negative patients. I do not know or work in academic hospitals, and no or no, that the training is the same. Okay. And the last question number 10. Is trauma care at trauma bay and operating room affected to COVID-19? Yes, trauma bay as overall is affected. For all the patients, yes, but only for positive patients. Yeah, Yes, since you have less professionals and procedures available for the risk of exposure to COVID-19. Yes, on both positive and negative patients. I do not work in academic hospital, and no or no. Okay. So after answer the questions, please click and submit, so your question or answer can be recorded. Okay. So a few more seconds for everybody to review the pool of questions. Okay, 10 quick questions. Let's see how everybody's answering. Okay, please remember to click submit after you answer all the questions. Okay, 10 more seconds. Please review all your questions. Okay, I'm gonna go back to Dr. Abutanos. He's gonna review the answers, and then it starts for the questions to the panelists and presenters. Michael.
Thanks, Valeria. So we'll see how this compares to last week to get all our data. So does your country or area have social distancing practices in place? You see the majority have. You combine both, having them and having them being respected. That's a separate question, but about 50% have them and they're being respected. As we saw from our speaker, that makes a big difference. Second question, does your country or area have lockdown procedures? And you see again that we have about a third said yes, being respected, but 25% you said yes, they have it, but they're not being respected. And about a third said no, we don't have that. Where does your area or region of practice fall on the curve of daily COVID-19 positive cases? And you will see this is very similar to what we saw last week. About a third still seeing some increase, significantly less now, only 19%, that's still increasing exponentially, and equivalent amount saying it has plateaued. So you're already seeing difference of numbers, especially as these are coming from various parts of the globe who are answering these questions. Now, do you have protocolized sequential treatment and guidelines? And you see about 80%, almost 80% said yes. And as again, I reflect on the fact that I believe that we have learned a lot from each other very early on. We're able to share our protocols, especially in sessions like these, and this has made a big difference. Number 5, are the ER and trauma providers in your facility wearing N95 masks at all times in trauma or ER care? You said 40% said yes, and about 30% yes, most of them. It's interesting, this will conflict a little bit, and I would like to ask Dr. Goddard later, and having the appropriate people wear the appropriate PPE, especially as you look at lack of resources. Number 6, is your facility performing tracheostomy on positive COVID-19 patients? And you see still we have about 25% said yes, whether it's open or trach, and we have about 40% are saying no. And this is still consistent with what we've seen last week. Number 7, is your facility performing laparoscopic or thoracoscopic procedures on any trauma patients or acute care surgery patients, being COVID negative or positive? And again, we see about 40% saying no, really shying away from laparoscopic or thoracoscopic procedures. And this would be a good topic for discussion as we move forward, especially as Dr. Kasarajan have mentioned and other speakers. This is going to be with us. So how do you deal with this moving forward? Is there going to be a difference in the care of the patient, and where do their rights lie? So that's a very important question. Did your hospital change trauma protocols or guidelines at Trauma Bay and the OR because of this COVID-19? And about 40% said yes. And equivalent 20 additional percent said yes for both positive and negative. So significant effect on our protocol and how we do things based on COVID, especially in the fact that we don't know even if our test is negative. So a lot of people have taken additional precaution. Our 9th question is trauma training for residents, so this is about education, and fellows at Trauma Bay and who are affected by the COVID-19. We saw that same number last week. You see the number that's saying positive. About 30% said yes, 12% said yes, but depending if they're COVID positive or not, depending on the test. And so the majority, I would say, have said that education and training has been affected. and this was very touched upon by Dr. Rizzoli as far as this can change how we train, and we welcome the invitation between Qatar and Virginia. Let me put it out there, Dr. Rizzoli. Number 10, is trauma care at Trauma Bay and OR affected due to COVID-19? You see about 46% said yes. It's just affect all teams exposure, and again about 20% that said yes on both positive and negative COVID patients. So we'll collate these all these answers compared to last week, especially as the disease has progressed, and then we'll be able to put out these results for everybody to see at the end. Okay. Should we go now to the questions and answers from the audiences?
Yeah, so everybody in the audience, please put questions on the Q&A, please, for the panelists of the presenters. Please put your question on the Q&A. Thank you.
Sure. I have actually a question and a comment to Dr. Rizzoli. It's really a comment based on when he put the last two things on the slide as far as did we overdo it before, especially with the appendectomies, etc., or is the second wave hitting us? I'll just tell you, just in the past 3 days here being on the Trauma and Acute Care Surgery service here at VCU, I have a big fear that the second wave is coming. We already had 3 elderly patients have delayed their care. One with horrible diverticulitis, horrible, that ended up with fistulization into the bladder. Another one just as horrible, and the third one with a necrotic gallbladder. All 3 of them have waited to come in. They don't want to come in. And I'm not, just saying this one of our fears is that we're going to start seeing, especially in the patient that we thought were most vulnerable, the elderly were hit the hardest by the COVID test, and now they're being hit again because they're the ones who have waited. It'd be interesting to see if you guys have seen anything yet, either in Qatar or in Norway. Maybe Tina can comment on that, or not yet.
Okay, just one comment. I think we saw exactly the same in the beginning, that we were wondering where all the appendicitis, where all the diverticulitis and cholecystitis and so on, but they came back after the same amount of weeks, more or less, as trauma. And then they came back. In the beginning, we seemed to see that they were sicker because they had waited longer, but now they are back, and we don't have the impression anymore that they actually wait that long. And I think that is due to good and ongoing information from leadership, and trying to also inform that it's more important that they come to hospital.
I would say, Marco, we are at the peak of the epidemics here. These are the worst days. So I think that people are still afraid inside their houses. But what we're seeing are ortho, for example. So patients who had some form of care that was not the best one for their extremities, for their spine, and they are already suffering. They are becoming more complicated as time goes by. So I think that not every tracheostomy that we didn't do are going to have a tracheal stenosis, but there's a good chance we will start seeing a number higher than usual, because we offered what I think was optimal care, and now we're not offering anymore. So my experience at this time have been with ortho cases, but I suspect that a wave of general surgery is just waiting for the epidemics to come down.
Great. Thank you. I think, does that relate similarly? There's another question I think was attributed to you as well, Dr. Rizzoli, from our Q&A. Says, could it be that we don't need early bone fixation because people are staying at home anyway, and there's no need to go back to work during the lockdown? It's almost, it's a self-fulfilling, basically, that at home they're not needing it, but eventually as they mobilize, they may end up needing it.
I think that we are in damage control mode here, right, with the epidemic. So damage control is great because it saves your life. Not necessarily the best you can offer. So I think that the patients are getting, I don't know, I keep on looking at some of the end-of-life decisions. that are being taken. And they're being taken based on resource availability. And that may not be the best way to make end-of-life decisions. I think there are so many other things that we could afford before. And now, during the crisis, we cannot. So I think that we're paying a price to going on damage control mode. And I suspect there will be repercussions and there will be long-term consequences to that. I don't think that our current surgical principles are incorrect. I think they are based on a lot of good evidence and experience. And I think that the second wave, it's not going to be a simple one. It's not going to be just people coming back with appendicitis. I think it's going to be a higher number of complicated cases. And now, as Dr. Kasijaran mentioned, how it's going to be in the States, right? Where you don't have a job now, and you don't have insurance to pay for your care. What's going to happen next? It's going to be, I think, a difficult world, as I say, to be lightly.
Okay, thank you. Dr. Schwartz, what are you seeing in Israel that compares to what you just heard from Qatar and from Virginia, as well as from Norway?
So luckily in Israel, I think we're now in the end of the crisis. We don't know if we will have a second wave, but for now, it seems that there are very little new patients appearing, and there are almost no new deaths. Israel is a country of 9 million, and we had a total of, until now, 280 deaths. Most of them in the first weeks, and I think in the last 2 weeks, we're seeing this decrease. I agree with Dr. Gardner that this crisis, the whole global crisis, is a crisis of a leadership decision and management. And if the leaders of the country manage this crisis in the right way and gave the population, the citizens, the right orders, the country suffered less damage. In Israel, most of the population are post-military service because it's obligatory. And because of that, every order that was given by the government was almost totally fulfilled. There was a very good obedience as a medical care personnel. You could travel in the streets, but the streets were completely empty during the high peak of the crisis. And I think thanks that we're now experiencing very like this decrease of these new patients. I agree also with the comments about the patient that stayed at home. And we definitely saw cases of patients that came very late with the ischemic bowel, and we could do just little to save them. But also in this case, the orders and the messages that were given by the government or by the leaders were very important. And immediately when orders were given to come to the emergency rooms as usual, like if you're experiencing a problem, just come to the emergency room. So people started to fill up again the emergency rooms, and we stopped seeing all these like very bad cases after waiting at home. So all these symptoms were just in the beginning of the crisis, and I think like when we went on with the crisis, the leadership started to understand where they can release part of the rules, and right now all schools and the kindergartens, everything is open back to normal. Also malls are open. We started to get students again back in the hospitals. So we're not completely normal, but we're almost normal now.
Dr. Scalia, before I ask Dr. Gardner, Dr. Scalia, you have last time described a unique, what I call unique system approach to the crisis in terms of how you distributed all the COVID patients across all your network hospitals. Now, in this emergence and reintegration, do you see the same approach needed, especially as we look at some delayed surgery resurging in a different wave?
Yeah, Mike, we're already starting a plan to redistribute the surgical cases over 8 or 10 hospitals. We just cataloged it. We've got 1,500 backlogged cases. This is not going to, get done in one place. I think the other thing to remember, which it's taken me a while to figure out, is we all talk about going back to normal, but we're not going back to normal. There are still going to be beds occupied by COVID patients. We're still going to have PPE issues. We're still going to have issues around airway management, and that's not going to go away. Even if we could do more cases, you need more beds, you need more nurses, you need more ICU doctors. This reopening is really it's as complicated as taking care of the COVID patients was. And I think that anybody who thinks that this is simple, we just flip the switch, is living in a fantasy world. This is going to be, even doing it in stages is going to be really, really complicated.
I'm going to ask Dr. Gardner next question, and then Antonio, I think, has a question for Dr. Barrera. So, Dr. Gardner, we have one question that came in from Enrique in Miami. Did Oslo have a real lockdown like Sweden? And from an epidemiological point of view, what class of individual and type of people got admitted with COVID?
So Sweden and Norway were very different because Sweden was much less strict. So we had not a complete lockdown, but our leaders were, or our prime minister was out very early and giving sort of strict quarantine rules and so on and so forth. Not complete lockdown. That was never the case. But like all the rules that we've heard about from all other countries, Sweden has not had that. They never actually stopped their fitness centers. They were giving advice to people, but not locking down. And that means they have many times higher rates of COVID, many times higher death rates than we have. Whether that is because of the less strict rules, we don't know yet. We will know. So, and what kind of effect that has on economy in the next stage, we don't know either. So time will show, basically. That the epidemiology, we saw our patients, we have had 224 or 230 deaths so far, about 8,000-9,000 tested COVID positive in the country so far. And those who die are old people, 84 years, so mean age 84. They are old and sick like everywhere else. The ones who are admitted to hospital, I think that's just, it's there. I think the mean age is around 50 or something. We had some young people. The youngest one who died was 41, but he had comorbidities. So it's not different from anywhere else.
Can I just comment here too? I think that's where the importance of testing too. So one thing is for you to close the whole city of Oslo. That's massive, right? The other thing is that you're testing, and all of a sudden you find there's a focus in a region, and you can actually quarantine a region, a section, instead of closing the whole city. And you can up and down your different measures that you can put in place. So I think that, again, I agree completely, Dr. Scalia. It's a different world now, and it's not going to change it as a switch. And I think that testing will have to pick up even higher than what it is currently. Everybody's going to have to be tested probably. Can
I just make a comment? That was
sure.
unclear. We never closed down Oslo. It's never been closed down. It's been sort of the quarantine rules to normal, the normal criteria with symptoms and so on and so forth. I think our testing is reasonable, and there is a thought of not wasting too many tests. We know too little about the tests. We know too little about whether you test the patients before you do surgery, whether how long does it take before it's actually positive, test what proves that the patient is not positive the next day, and so on and so forth. We're urging to try to keep isolation 2 weeks before elective surgery now, in order to try to avoid them being positive at the time of surgery. But I think that there hasn't been a reasonable way of dealing with this. And so far, the numbers show that seems to be good. And we'll see where we go now with opening up and doing more towards normality. I agree, we're not going back to normal, but towards normality. And I think the most important is that we continue keeping our social distancing and maintaining focus on symptoms and then testing.
Thank you, Dr. Gardner. I have a question to Dr. Barreira, and then I would like to Dr. Kassir-Ajjan to answer that. We saw that in countries like Israel, like Qatar, even Norway, the population not that big, they were able to contain, and they're already planning reopening. But Dr. Barreira, when he presented his data for New York, he was in the peak. The situation was out of control. They have massive impact on the healthcare and the population's life. And now, during the last weeks, we've been showing the numbers coming down, some hope coming, but New York is going to reopen in a few weeks. But the density is there, the metro is there, the people close together, the buildings, etc., etc. So the question for Dr. Barreira and for Dr. Kassir-Ajjan, how do you see the reopening in your region? So how are you expecting the second wave? Do you think we're going to have another peak, going to be a continuing prolonged plateau, or increased number of cases that are going to last for 1 year or until you have the vaccine? And also we do disaster. So if it's going to last a long time, how going to be medical education for residents and fellows and for medical students in hospitals that are busy taking care of COVID patients? So first, Dr. Barreira, then Dr. Kassir-Ajjan, please.
Thank you. If I get this question right, I'm going to buy the lottery numbers also. It's very interesting. We are already ready for a potential second wave. We have, as I showed in the last meeting, we have the COVID unit, which has 60 ICU beds, and we can potentially have 100 ICU beds for a potential second wave. Long Island Jewish is going to be the hospital that's going to be receiving the most patients from the system. Our system, as you know, is 25 patients. We have one, as of now, we have one COVID-free patient, which we have started all the surgical, surgical efforts are there right now. We have over 20,000 cases that are delayed, and the ambulatory cases are going to start opening as soon as, I think, a week or 10 days from now. And it's, as Kalia said, logistically, it's almost a nightmare because we have to change everything. And what we have done is we have treated every patient like a COVID patient. With the experience of the AIDS problem a couple of decades ago, that's how we're doing it. The surgical training has been, for the residents and fellows, has been disrupted. We started with our interns last week. So finally, whoever is in academics, July is not going to be that stressful. It started Monday. And I think what's going to happen is everybody that's coming here, we are testing, and we are being surprised of how many asymptomatic patients are coming in for hernias that are COVID positive. As of yesterday, we had only 5 ECMO patients left with COVID, 143 patients who are COVID positive left on the floor from the close to 900 that we had at the peak, and we have only 36 intubated patients, of which our mortality at the present time is around 65%. So we'll see how we do in the next couple of weeks. We have tested 7,000 patients in LIJ, and we have discharged close to 1,800 patients from the hospital. So it's been, our hospital received the blunt of it. That's why the system, the Northwell system, is giving us most of the patients now. And probably we, because we have the most experience, will be receiving most of the patients here. And surgery has started orthopedics in in a sister hospital and neurosurgery, and now we're starting with all the oncological patients. We try not to, this is an oncological hospital, we're trying not to have oncological patients with a COVID positive unit. We have 2 COVID negative intensive care units in LIJ, but there's 2 intensive care units which received COVID positive patients that had surgery or some other procedure.
Thank you, Dr. Barrera. Dr. Kasirajjan, so what's your vision regarding education and the next wave? Please give your thoughts, please.
We have started reopening as of about 2 weeks ago. We started putting back kind of semi-urgent elective type operations. And that's kind of moving along. We're almost at 90% of pre-COVID numbers. Now, the number of COVID patients in-house has continued to stay stable and maybe grew a little bit over the last couple of days. I suspect we will have a long plateau of patients, anywhere between 50 to 100 patients in-house for many months, perhaps for a year or 2, before the natural history of the pandemic, where population develops some level of immunity, and whether we can get a vaccine that's actually effective will happen. So I think we, as all the colleagues on the panel and other members have said, we're in this for the long run, and we had to be prepared to handle this for a long time. The behavior of the virus and the disease caused by it has also been very, very unusual, in that we have seen some very young patients with significant complications with vascular thromboses and other things that we don't fully understand. And I think there's a lot more to be understood about the disease process itself and what is going to happen over the future. Now, in terms of the trainees, the graduate medical education, in terms of the surgical residents, the medical residents, the plan is for them to come back to work in July. The new grads are going to start in July. The existing ones are all working, and they're doing as best as we can in terms of their training. The main area that has impacted the training is the outpatient arena, where now we're doing a lot of virtual visits, and it's hard for trainees to participate in virtual visits. The inpatient training, and I think the operative volume, I think as our numbers pick up, will be okay. But we do have to think about new paradigms of training and virtual reality and other things as we go forward. Now, the medical students are a little bit different. They were not allowed to come back. And I believe there is a plan to reopen the medical students coming back into the system to actual clinical care in the next 2 to 3 weeks. Now, the first and second-year medical students will likely be doing more virtual learning than in classrooms, at least for the near future. Now, beyond that, high schools, colleges, we don't know when they'll reopen and what's going to happen and how all that's going to be impacted. So a lot of it is very unknown. We do think there will be a second wave, and that, as it happens in any pandemic, over the course of the pandemic, and what the impact of it is at this point, it's unclear. I know if we have to learn from our colleagues in New York, I think we need to be cognizant of lessons from other cities and other states and other countries, and be very, very careful. I just don't think we understand the virus. I think all of us underestimated, what the impact of this would be and how potentially infectious and transmittable this is. And I think we underestimated the lethality of the virus. We thought this would be a mild disease in most patients, and I don't think that's the case. Even in children and infants, we're seeing now inflammatory syndromes like the Kawasaki's disease caused by the virus. New York reported a cluster of patients. I think we're in this for the long run. How we learn and adapt and learn from each other, and I think would be very, very important. So.
Great. Thank you, Dr. Kasirajjan. I have a quick question for Dr. Bofar. So, Ken, in looking at your really impressive lockdown that you have done, And what are the consequences you would think now if you add the 50% expected unemployment that you have, the significant success in your lockdown? Now you may have to pay for it with patients who may come later during that second wave. How have you guys been preparing for this?
That's a great question. The easy answer is we haven't got the slightest idea because we don't actually know what is coming. The reason I say that is of the two major urban centers where the concentration of cases are, Johannesburg, our American style state, what we call a province, is 12 million people. We've had 2,000 some cases and 24 deaths in the nearly 3 months since we've been dealing with the disease. Cape Town and its areas is half the population, has around 6 times the number of cases, and that obviously depends to some extent on testing, but is running at about 200 deaths. And we cannot account for the vast differences in areas of the country, and we have significant unknowns, one of which is the country's 15% HIV positive. And although we've never had Ebola, we've been very involved with it. So we have a track record of being very involved in viral management and viral disease. So the government and what we have here, which is called the National Institute of Communicable Diseases, are working very closely, very scientifically on the whole. And the lockdown is between 8 to 10 weeks. And the unlocking is going to take some time. They've made provision for differential unlocking depending on the incidence of disease in an area. So I wouldn't be surprised to see the Cape Town area unlocking differently to the Johannesburg area. And so to try and run a nationwide protocol of how do we start surgery in the hospitals when different areas with the same demographics have got completely different numbers is still up for discussion. We feel that the hospital unlocking is going to be very similar to national unlocking, that in stages we are already converting now to elective cases and emergencies. Tina Garda's presentation was very much a mirror image of most other people. Our emergency numbers didn't change. One of the things that we have here, nobody's actually mentioned it very much, is a real reluctance of the public to go to a hospital to seek care because they perceive that they're going to get COVID from it. And a massive resistance to patients going, for example, from trauma to rehabilitation centers, even though their incidence is very low. No, I'll make a plan at home because I'm frightened of any hospital. So we have to do two things. We've got to unlock in a sequential fashion, but we're going to have to sell to the public that the hospitals are safe. And I think that's going to be the biggest challenge that most people worldwide are going to face.
Thank you very much, Dr. Bofar. Dr. Bofar, you just put here, Johannesburg, 12 million people, 2,300 cases, 27 deaths.
Western Cape is Cape Town.
Okay, Western Cape, 6 million people, 200 deaths. And you're seeing right now in South America, and we're going to talk about South America next week, Brazil is sky high, and a lot of other countries are going crazy number of deaths in your case. So what did you do? And you had time to plan, you're always behind Europe. So how did you manage this situation to have these great results in South Africa?
I think two things, or maybe three. The first is we have a slightly different population. Our elderly population for African environment is in the rural areas. They look after the kids while the parents go working. So we have a far, far lower number of older people than, for example, Italy or Western Europe or the United States. We also have, partly as a result of HIV and for other reasons, fewer obese people than many countries in the West. So some of the risk factors are not as high. That's the first thing. The second is we had our first cases came in 6 weeks after Italy. So we have had the ability to learn from other countries' mistakes. I'd love to see one of these webinars run of what have we learned now that would make us do differently what we did 6 weeks or 3 months ago. So we've learned a lot from other people's mistakes and from other people's management. And the third thing is we probably had, together with New Zealand, the world's most vicious lockdown, with a prison sentence or a fine, a criminal record for walking on the street. So that bought us the time to get the infrastructure prepared. We've had our first case 4th of March, and we're now end of May. And nationwide, we're looking at 18,000 cases, and nationwide to date, under 300 deaths. So we've had the luxury of preparation time that some countries in South America, because their lockdowns weren't as effective. Sadly, I think, and the same applied to Italy and others, I think their ability to prepare for it, and I compliment Sandro Rizzoli, because they've again got a very careful sequential protocol going, but they had the time to plan for it.
Thank you very much, Dr. Beaufort. So I have a last question. Dr. Scalia, what kind of steps are you using to perform surgery? How are you using PPE for surgeons? How do you clean the PPE? Please comment this question from Dr. Claudio Vasquez, please.
We're trying to preserve the PPE to the greatest extent. We're using the Cavicide wipes to repurpose the PAPRs. We've had a terrible time keeping the PAPRs in. We have enough N95s, so that has not been a huge issue, but we are employing, let's see, 1, 2, 3, 4, about 5 people every day shift and 3 people every night shift to simply help people on and off with the PPEs and to clean the PPE and be sure people are taking it off safely just in the operating rooms. And so we've burned a lot of personnel costs trying to be sure that people stay safe and that we don't lose PPE, because that stuff is going to become more and more like gold.
Thank you very much, Dr. Scalia. So, Dr. Abutanos, your final comments, please. Dr. Rizzoli, your final comments, please.
So my final comment is just thank for the opportunity to speak. I think that the next step in restarting life is going to be testing for us to make any epidemiological decisions right now, even which parts of the country to open, which parts of my hospital. If all the urology or all the OR nurses are tested positive, I can't open the OR. I don't have workforce to open the OR. So all the decisions now, from now on, are going to be made basically on tests, despite their limitations. So I think that that's the next step, and then a gradual resumption of normal activities. The world is going to be different from now on. And thank you, Dr. Martos. Thank you, Dr. Abutanos, for the opportunity to speak.
Thank you, Dr. Rizzoli. So, in name of the Pan American Trauma Society, American Association for Surgical Trauma, International Relations Committee, World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University, VCU, I'd like to say thank you very much for all the presenters and panelists for this session. We had another great discussion. Next week, we're going to be focused on what's happening in South America, the response to South America, and the problems, the challenges that have been facing over there. Some countries are fastly going to the first places and leading the table of case and mortality, unfortunately. And we're going to be discussing this next week. I hope everybody stays safe. Thank you again for a great discussion today. See you all next week. Thank you.